On to the next speaker, none other than Dr. NIVEAN from MNI Hospital, Chennai, and he's going to talk to us on phaco in mature, that is white cataracts, hypermature cataracts. It's here? It's here or that? That's it, okay. And we can take the questions at the end of the sessions.
Thank you, sir. So I'm Dr. NIVEAN from MNI Hospital, Chennai, and I'm going to talk about phaco in white cataracts. As you all know, white cataracts pose a challenge for all cataract surgeons. That is the first challenge. And second, it is very difficult to talk after Mohan Rajan sir because he's already explained and shown how beautifully chopping can be done and how easily it is done. So I'm just going to show some tips and tricks about managing these white cataracts and different types of white cataracts. So this particular one is a slight intumescent cataract. As the sir has already summarized, that staining is very important. Whenever you don't have a good red reflex, don't hesitate to stain, because getting a good rhexis is one of the key things for any phaco surgery. Good amount of viscoelastic fill, because you have to flatten the chamber. As you could see in his videos, he put the soft shell technique so that you make sure that the anterior capsule is always flat. So this is one of the techniques I do in these intumescent cataracts, is the fine needle aspiration. So just poke a 30 gauge needle and then aspirate those liquefied cortex, because you can see those liquefied cortex being aspirated. So once that happens, the intralenticular pressure decreases. So now this cataract behaves just like a normal white cataract. So it is easier to do the rhexis. And the third thing is doing the rhexis after initiating the flap. Throughout the procedure, make sure the triangle shape you can see and the flap is always facing downwards. It is only when the flap lifts up, the tendency is there to extend. And usually during the subincisional area is where it actually extends. So always don't hesitate in these white cataracts, not for all cataracts, to come out always, put in some more viscoelastic, flatten it, push it towards the center, and then continue the rhexis. It is not necessary to do the entire thing in a single go. When you do sometimes superiorly, there again the subincisional is where it tends to run. And finally, try to bring the force towards the center and aim for ideally 4.5 to 5 millimeter rhexis. So you can use whatever you're comfortable with. Here again, you can see the slight extension going to happen. So the third thing is always stop. When you think there is a doubt of element that is slightly extending, don't try to continue. Stop, analyze, put in viscoelastic, and then the force towards the center, so that you're trying to bring the rhexis back and complete the rhexis. People who are comfortable with the forceps can also use the forceps. So the cystitome or the forceps, so whatever instrument you are comfortable with in doing the rhexis is ideal to do the rhexis. So here again, pulling it towards the center to get it back inside. So once the rhexis is done, the choice of phaco is either the stop and chop or the direct chop. So this is something like a modified direct chop, wherein you make a burr hole in the superior part. So two things it helps. One, it helps you create a crater. And the second, when you bury your phaco probe inside, you go more into the core of the nucleus. So this helps in the chopping method. And as I said, the vertical chop is more preferred here, because you don't have to go under the capsular margin. And watch for the epinucleus plate cracking. So unless there is a separation of the epinucleus plate in these cases, as you can see that piece, that separation of the pie was there, then you start removing the piece. In these types of harder cataracts, mature cataracts, I always prefer to remove one of the pie of the pieces, because one, you can see that you get more space, so you can actually see, because these are large cataracts. The other, moving them inside the bag also makes it easy. And you all know most of these cases, you're not going to have a lot of cortical fibers, just some remnants. So either you can put the lens and also aspirate the cortex that is there in the periphery. And usually these are all these 6 sticky cortex, and most of the times the central zone is always clear. I always prefer to put the IOL under irrigation. But again, the trick here is you should make sure all the wounds and the sections are watertight and there is no collapse of the anterior chamber. So why a good rhexis? As you can see, the overlap of the capsular margin. So PCO prevention is not only about the type of IOL, it is about the surgery also, how you get the good overlap, so that all the benefits of the IOL are made use to lessen the posterior capsular opacification. So these white cataracts, so this was a simple white cataracts where it is actually softer and not very hard. So sometimes you see white cataracts like this, but you can see that underlying brown component there. So you know these cataracts are a little more harder, so this technique is not going to work. They are not the intumescent cataract. It is just in the stage of going into hypermature, and you can see slightly being mobile. So here again, after staining, again the rhexis. So in all cases, rhexis is the key here. Why slightly smaller rhexis is because in case you have a rupture or something goes wrong, you can always keep the lens in the sulcus or have an optic capture. So rhexis is very, very important. Here again, burying it into the core of the nucleus and initiating the chop. As I told from the first case, this is a slightly harder case. As you can see, the crack did not go through. So I'm not doing it in the same place. I'm rotating it. I'm trying in a different plane. So again, going for the crack. So unless you get the crack and separation of the piece, don't try to pull the nucleus out, because that time you see the hemisphere of the nucleus coming out and the whole bag, there's become stress on the zonules. So once you have this separation that happens, then remove the piece outside, because once you get that, then it is just like doing any other normal phacoemulsification. Keep topping it up with viscoelastic in the initial stages, because you are using more phaco energy than in the normal cases. So don't hesitate to come out, put in viscoelastic and go back and complete the cases. Then there is no particular method. Again, the comfort of the surgeon. So you can do a stop and chop method also in these hard cataracts. So it looked white here again, but once we removed the component, it was actually a very brown cataract underlying here. So here I'm doing a normal trenching method in phaco 1. Yes, just use little more phaco energy than you usually do. So this is again a modified stop and chop, where after doing the trenches, because the central place is where the thickness of the nucleus is the maximum, so that is where it is difficult to crack. So now once you have this trench in the center, you can go to the periphery there and hold it, and then the cracking becomes slightly easier because you're separating only that area. And center, since you have a trench there, the plate is thinner and it easily cracks. So this is another technique where you can do a modified stop and chop technique, and this is the other side, just rotating it and see the crack happening. See, once you see that line dividing, and then you have almost completed 50% of the surgery here. So yeah. So just by following the basic principles of phacoemulsification, using the right power of the machine, don't be hesitant to slightly increase the power, because sometimes we are stuck to the same parameters in the machine, and that is when we start pushing the nucleus. When you push the nucleus, then the zonules, which are already weak in these cases, break, and then we land up into problems. So there is no harm in increasing the power in such when you deal with these hard cataracts, isn't it? So here again, at the end of the case, you can get very good clear corneas. So then the last type of white cataracts will be when you have a hypermature cataract like this with a leaking proteinaceous material with the phacolytic glaucoma. So here again, it was planned for phacoemulsification. So here also we have a mid-dilated pupil. You can see the PXF in the margin, and again this liquefied cortical material that is coming out, which is being washed. You can either use the Simcoe cannula also. Here, why I'm using the forceps is you only have a small nucleus in these cases. So you won't have a grip when you do with a cystitome. So that is why in these cases, forceps is actually a preferred choice, and it is easier to do with the forceps. And this, I'm doing a new technique called the IOL scaffold technique. And this can be done only in cases where you have a small hypermature cataract, because these cataracts are very hard and they keep moving into the bag. So it's very difficult to crack it, one, and then two, the bag is also weak. So sometimes when you see the end of the surgery, the whole bag crumples and comes out of it, isn't it? So what I'm doing here is injecting the foldable lens underneath the hypermature cataract into the bag. So again, here visualization is very important. Yes, I did not use the hooks in this particular case, and you can see then just making sure I dial the lens into the bag, the capsular margin seen there, and then chopping has to be done in the center, because anytime if you catch the iris in these cases, then the whole surgery becomes messy and it becomes very difficult. So stick to chopping only in the central area. And here again, the IOL acts in two ways. One, when it goes into the bag, it stretches the bag. So it almost acts like a CTR and keeps the zonules up here. And then it also acts like a scaffold. So it prevents any PCR happening in these types of cases. The only thing is phacoemulsification should be done slowly. Don't waste the phaco power unnecessarily, because you're doing it slightly above the bag, isn't it? And keep topping it up with viscoelastic. So once this is done in these types of cases, definitely there is no cortex, because most of the cortex is liquefied. This is just to show the IOL inside the bag and a safe phacoemulsification being performed. Here again, I would like to highlight this can be done only in cases when you have a small, hard, hypermature cataract. So thank you once again, and big thanks to AOS and Dr. Mohan Rajan sir. And before I finish, I cannot stop without saying there is another technique called the punchorhexis. So that is another method invented by Dr. Mohan Rajan and has won many awards. So in these types of intumescent cataracts, you go with the bevel down in a burst mode. So here again, what happens is The burst of energy not only decompresses the anterior part of the lens, but also because of that energy, the pushes the fluid from behind the lens, and the same probe can be used to aspirate. So this is another method which is very useful in doing in cases of intumescent cataract, but there is a slight learning curve, but I think everybody should try it and do it to get the rexes in these types of hard intumescent cataracts. The other thing is the tip. Initially, these were my cases, and I learned most of my phaco from Dr. Monrajan only. So you see the tip is very small. So that means what happens when you're doing chopping, it doesn't bury inside. Can you see that? So most of the time when you're chopping, it keeps slipping away. So that is something we find in it. So he saw my videos and told me that the phaco probe, if you see in his videos, it's slightly longer. So you get more burying. And when the burying is good, the chopping happens even better. The third thing, in these types of hard cataracts, you get what is called a chatter, because there can be blockage of the thing. So we should be able to recognize this so that we don't waste a lot of phaco energy. You can see here the repulsion of the hard cataract, which is all going on well. So once the piece repels, there is something to do with the tubing system. So always stop, reanalyze if there's any block, do a priming of the machine, and then once you see the good followability. So in these types of cases, you should pay attention to whether what is happening, because the amount of phaco energy you want clear corneals. As in this case, it was a multifocal. You want clear corneals, and the patient's expectations are very high. The other common mistake here is architecture of the wound. See, once you have a bad wound architecture, in these cases, it is going to be a big trouble, because you got the iris coming out of the wound, leakage of the wound. Once the wound starts leaking, the AC shallows. So because the AC shallows, you are not able to have a good followability or chamber stability. So one problem leads to the other here. You can see the chopping is not happening, and they're putting too much of stress on the zonules, as you can see here. This is again because of the shallowing of the anterior chamber, because of the wrong wound construction, and at last you see the zonules all breaking, and this is what is going to happen in these types of hard cataracts. So I think proper preoperative planning, assessment, keeping the right instrumentations, making sure you have the hooks, you have the rings, you have the CTRs in place, is what is going to help us in these types of challenging cataracts. So I think Dr. Monrajan again showed the same one of these videos in the hard cataracts. Again, I'm just doing a burr hole there. So this also helps in debulking the nucleus and getting a good purchase. And the last point I like to highlight is, you don't have to get a crack in the first go itself. So what happens is, there is a crack here, but this is not gone 100%. So don't be in a hurry. So you have to do what is called like a multi-layer cracking till you reach the epinucleus plate. So you have go deeper, stay there, deeper. So your second instrument goes deeper and deeper, and then till you get the crack of the epinucleus plate. So this is like a multi-layer cracking till you have the separation. So once you have the separation, but you can see the movements are all within the back. There is no too much of stress on the zonules. And then one piece I always prefer to remove, as I've said before, because it gives you some space in these types of hard, bulky cataracts. And this is how the case ends up. So once again, thank you, sir, for having me in your session. Thank you.